emailed out to those of you who are attending today. With that, I'd like to introduce our speakers today. Today we have Frank Rutard as one of our speakers. Frank's been here at UNMC for going on 29 years, excuse me. He's a certified health physicist with a master's in radiation health physics from Georgia Tech. He's as the director of radiation safety here at University of Nebraska Medical Center and Nebraska Med. He's involved with all aspects of the safe and compliant use of radiation, both here on campus as well as at the Omaha VA and Children's of Omaha. And then we also have Angela Leek. Angela Leek, PhD, CHP, is the Director of Radiological Solutions and Regulatory Affairs at Summit Exercises and Training, where she develops comprehensive solutions for radiological emergency response and regulatory needs. Prior to this role, Dr. Leek spent 16 years at the Iowa Department of Health and Human Services, with the last 10 years overseeing the Radiation Control Program. Her responsibilities included serving as Iowa's liaison to federal agencies and national organizations, such as the Nuclear Regulatory Commission and the Organization of Agreement States. Dr. Leek's contribution to radiation protection are extensive, with numerous publications and invited presentations. She is a certified health physicist with the American Academy of Health Physics and serves on the board of directors of the Health Physics Society. Dr. Leek co-authored a chapter in the Oxford Handbook of Nuclear Security and has published multiple peer-reviewed articles. Her international experience includes workshops and exercises in various countries, and she's contributed to initiatives with the National Academies of Science, Engineering, and Medicine, and several federal agencies. Dr. Leek earned her PhD from Iowa State University and an MS in Radiation Health Physics from Oregon State University. With that, I will turn it over to Dr. Leek and Frank.
Great, thank you so much. And hopefully my screen is coming across for all of you. Can you verify that, Thomas?
Looks good from my end.
Perfect. All right. Well, thank you everyone so much for joining us. You may remember Frank and I from last year and the work that we did with many of our regional partners on the annex for radiation response, working really closely with the healthcare coalitions and other partners. I believe this year you have all been working on the chemical annex. And so we wanted to circle back around since you've kind of done some of that work in many of your partnerships, and talk a little bit about the community reception centers and how they play in an entire CBRNE incident, but also focusing in, of course, because Frank and I are from the radiation side of the fence, how the specific specifications of a radiation incident drive the needs of a community reception center. So we're going to start kind of big and focus our way in, and hopefully leave you with some good ideas and questions, and a template at the end that you can use to do some work on your own. So before I get too far into the topic, just wanted to give a little bit of an overview of who we are, what we're doing. As a part of the Region 7 disaster health response ecosystem, we are a part of a larger ASPR initiative, which has 4 of these response systems across the country that work across their regions and nationally to align plans, procedures, and policies for clinical excellence in disasters, and build partnerships across these networks. We consist of specialty teams, and so in the Region 7 DHRE network, we have a specialty team with individuals like Frank and I in each of these areas across the spectrum, from biological to burn to trauma, radiological, chemical. And so if you're interested in finding out any of those, please visit the website, which I'll have on the next slide. Specifically, though, Frank and I represent the Radiation Specialty Team as a part of this group. And a lot of our initiative is to support all of you from the aspect of planning for a radiological emergency from a clinical aspect, but also in understanding what the response might entail as far as risks to the public. So today, what we're hoping to get through is to talk through what are reception centers. And there's a lot of terminology used for these, and we're going to explore that a little bit before we dive in to specifics. And we want to talk about a little bit, how are these centers already incorporated into your plans? Because I'm sure many of you have already used a reception center. So we want to talk a little bit about your real life activations, and we're going to use a system called Slido. Hopefully you've all used that before. It's fairly easy to use, but have your phones ready because you'll be a QR code that you can scan or a website you can go to answer these questions. So have that ready. CBRN incidents, and we want to talk a little bit about those and the components of that really lead to the need to have a different type of reception center for these. And then we want to dive into the community reception centers themselves and decontamination, specifically to radiological incidents. So before we start, I just wanted to provide a little bit of an overview. When you look through the various resources and guidance documents from FEMA and many of our federal agencies that provide documentation and guidance for response to all sorts of incidents, whether they're natural disasters or CBRN type incidents. We use many different types of terminology, and I don't think there's any hard and fast rule on how these terminologies are used, but I did want to go through a few of them just so that we are all on the same page as we're talking about the community reception center. And I will say, in the radiation world, when we say a community reception center, most people in radiological emergency response immediately think of a radiation specific reception center. Not everybody thinks that way, especially if they're not in the radiation world. So I should, implore those of you who commonly refer to a CRC and think, oh yeah, that's a radiation reception center. Don't assume everybody's on the same terminology page as you. And vice versa. If you're not in the radiation world, realize that somebody might forget to put the word radiation in front of that CRC terminology. But back to the basics here. So when we talk about a shelter, often, shelters can encompass many things. It could include family reunification. It could include a registration. It could include all types of other informational resources for those individuals that are coming to the shelter. But it is fundamentally a temporary location for individuals to stay while they're displaced. So it's meant for a longer term or cyclical type of inhabitation versus just coming there for some services and leaving to go to another place. A hospital family information center or a family support center is a healthcare facility-based support center that's immediately stood up after the incident or while the incident's still unfolding. Because healthcare facilities are kind of already there, they have some infrastructure. And so these types of things can be planned for using that healthcare infrastructure and providing this community support in addition to the clinical support that might already be being provided at those facilities. As the situation unfolds a little bit further, family reception centers start to be stood up, which are potentially away from these hospital locations. And they're centralized temporary locations that are set up immediately post-incident. They may not have very many services, but they're kind of a unification center. They're a place where you can collate a lot of shared resources, a place for the community to go to get them away maybe from those healthcare facilities that are treating and needing to manage patients. Further then into the 24 to 48 hours after the incident, family assistance centers that are meant to be more secure, stable, longer, and I'm going to use in quotes, longer term facilities that provide a range of services. So maybe some of the support assets from the federal agencies are located there. So you can sign up for FEMA reimbursement. You can sign up for things that are more than just your local community right in the middle of the incident support. And then, so in the middle there where I have information and service, human service centers, that's the bucket of those middle three are kind of used throughout FEMA documentation as information and human services centers. So the shelters are something different. And then at the other end, we have specific types of reception or community centers that actually provide very distinct services. And the radiation CRC is going to be that for radiation, but one that might be familiar to you is a point of dispensing location. This is a location where medicine, vaccines, other medical supplies can be distributed to the public, and public health agencies have plans for these pods throughout their communities. And we'll talk a little bit about how that can fit in those plans that are already pretty well vetted out in most jurisdictions can be leveraged to support the radiation community reception centers. So here's that Slido opportunity here. So we're going to use this. So if you take a minute, you can either go to slido.com and type in that number, or you can scan the QR code. And I'm going to just pause here for just a moment while you guys do that. All right, and this joining stuff will be available on each slide as we go forward as well. So we'll go ahead and move forward to the next slide. So what names do you use in your existing plans to describe the various public assistant community reception centers? And of course, have not been all inclusive. There are many other types of community centers that might be necessary in various types of incidents. So feel free to, drop those in there. Very good. Yeah. So reception centers getting big. The bigger the item, the more entries there are. So community center, reception center, family reception center. So yeah, we're seeing a lot of those terminologies. Of course, they're coming from the guidance. So no surprise that we're seeing a lot of those same names popping through here. Right. And yeah, so as we see the term shelter popping in there as well. So, as we think about some of these names and the way they're used and some of the definitions that are in some of the guidance, maybe keep in mind, how and where those terms are used in your plans. So we'll go ahead and go to the next slide. And this one, do you use one name for all types of the centers, or do you use different names for different purposes? So yeah, it looks like the majority so far of people answering, are using a different name for different purposes throughout their plan. But there's a good percentage there where we're using the same name for all of them. So which, in most cases, especially for providing family support or unification or information or things like that, that can work. But for those of you that are using the same name for all, or depending on what naming convention you are using, keep that in mind as we talk through some of the details throughout today, and how you might want to use a different name for some of these CBRN reception centers that we might talk about. What types of real world incidents have required you to open one of these centers that are described in your plan? And I think this is a free type as well. So, yep, COVID, floods and storms, an apartment fire. That's a unique, distinct one. I'll be interested on the nuclear event. Who had a real world nuclear event to open one of these? So during the Q&A at the end, talk a little bit about that. So train derailment, that's a interesting one. The Palestine train derailment in Ohio was probably a great example of a pretty extensive, community support, both in the short term and the long term for that. Power outages where they're not going to have their resources in their home, wildfires, drinking water contamination. Yeah, so various types, and lots of flooding, severe weather, vaccine administration and COVID. So we've had some practice with these, right? So my next question then is, what types of services did you provide at these centers? And of course, they're going to range between, what type of an incident it was, but just generally what types, and you can put multiple entries in here, whatever you wanted to do. So medical countermeasures, FEMA applications, food and testing, family information. Sure. Yeah, and especially with COVID, we had a lot of the testing, which again, if you think about that and needing to manage, biological samples for testing, think about sampling you might need to take during a radiological or a chemical incident. So, how could you incorporate what you learned through some of the COVID mass testing that we did and how that might apply. So pharmaceutical distribution, overnight shelters, reunification, family information. Yep, all great, great options. Mental health services. Yep, that's great. We're going to bring that up a little bit as well going forward. Okay, so this is the question. How well do you think your plans worked for setting up and operating these reception and support centers for the incidents that you experienced? We'll let this settle in a little bit before we talk about it too much, but you can kind of see it's good that good's toward the top so far. It's good that they seem to be, working well and even very well. So the good majority of people, the plans are going well. Although we can see that right there behind good and very well is the not well. And I'm sure it's various aspects of the plan. And, I implore you to think a little bit about what was really good about your plan and enacting it in a real world, and what were the stumbling areas. And so as we talk through some of the specifics of what's needed in a community reception center for specifically radiological, think through if what we're saying are any of those points of the plan that maybe didn't go very well or did go very well, so that you can think through what maybe you might want to focus on as you might think about establishing a community reception center plan for this. And I'm so glad there's no one that says what plans. So you all know there's a plan. That's great. And then have you ever provided community support for a real world CBRN incident? So this would be setting up one of those reception centers for a CBRN incident. Usually we hear about these if they're major. So got a small percentage there that have done this before. So any insights that you have, any thoughts that you have, or questions that we can talk through to help others think through maybe what lessons you learned during this real world application of your reception center plans would be super helpful. So we'll make sure we have some time at the end to talk through that. So all right, so now we'll dive into some of the meat of this. So what makes CBRN, or chemical, biological, radiological, nuclear incidents, different? The main thing is that they have unique features that are mostly unfamiliar hazards to the community. So really the needs of a community in any sort of a disaster are not really that different. If they are displaced from their homes, they have the same needs, whether that displacement was from a flood, a radiological incident, a chemical exposure, whatever that might be. It's just, so all of those human factor needs, all of those logistical needs, those food and shelter needs are all exactly the same. We just have these additional components that get added to it. And some of that is a public fear factor of the unknown, a lack of understanding. We might have a contamination that we need to control for. We might need to be doing some technical assessments to understand how much of an impact this chemical, biological, radiological, or nuclear incident might pose to the individuals or to our workers at the centers. And specialized resources are often needed to help translate what this, what is the actual risk? Okay, we have this measurable amount, but is it a big deal? Is it not a big deal? What does it mean? What could happen? And all of those kinds of questions. And so really, there's just a small facet of things that are different about supporting your community from a CBRN incident, but they're very important. And they're a little bit obscure if you don't normally practice or play with these individuals that have these specialized resources or knowledge. So it's important to look at your plans and say, okay, my plan is good here. It's good from this aspect, but I can adjust it so that I can make sure that all I have to do if it's a CBRN incident is pull this trigger and now these specialized assets show up. So really the big deal with a CBRN incident, and there's other components, and Frank will go into some of this when we talk about the reception center components for a radiological incident. But the big thing is there's the potential for exposure to whatever agent is of concern. But we can also have contamination, which means you're bringing it with you wherever you're going. And so exposure is you're subject to the material. So from a radiological perspective, maybe it's a radiation device or an exposure that is in a box and you don't touch it, but you're near it. And so the radiation is reaching you and giving you an exposure, but you don't actually touch or pick up any of the radiation. So when you leave that area, say go to a community reception center, you don't have any radiation contamination on you because you didn't pick any of it up, but you did get an exposure, which could pose some biological concern. Chemical, the same sort of thing. But in most cases, you have to get that on you or in you to have that effect. So what we're really worrying about at the community reception centers is external contamination. So people bringing it with them and transferring it to other things or people, where then other people transfer it and it just continues to transfer. Or internal contamination, where they might need some medical countermeasures to actually either negate the effects of that chemical or treat the biological exposure or move the radiological material through the body so it doesn't reside there for a long period of time. But there could also be some other assessments that are needed for the amount of exposure someone got, even if they didn't bring it with them to the community reception center. And so Frank will go through some of the ways that we do that. So the big thing that's the additional piece of a community reception center for a CBRN incident is that it's going to require an assessment of the individuals to determine whether they need decontamination or treatment. And the strategies for decontamination are going to vary based off of the incident type. But no matter what, it's usually a good idea if these efforts are separated from general population support. So if you have one center set up and it's registering all of the people who were displaced but weren't really in the affected, the true affected area where the contamination occurred, if they come to the same community reception center, they might be in line with a bunch of contaminated people, and then they would have never encountered that contamination otherwise. And you have a lot of additional resources that are necessary. And again, Frank will go through a lot of those details about the types of facilities that you need. And so the more people you have there and the more of them that are being used for the screening and decontamination purpose, the less space and the less resources you have for the other general human factors and family reunification and other types of activities. So just for context, this is an example of a radiation incident and the areas where we might see detectable contamination. Now, this doesn't mean that all of these people would need treatment, that all of these people would have any effects, that would even be, and for the most part, most of this would not be any sort of a health concern for any of these individuals. However, we are really good at picking up radiation. Our detection equipment is very sensitive. So if anybody from any of these highlighted areas showed up at the community reception center, they probably will trigger the radiation meter. And so think about how many people live in all of these areas and how many communities might be impacted from this, just, even at a very small contamination amount. But you may be telling people in Vinton that they do not need screening, but they want it. And they show up at the community reception center and they're going to trigger one of the radiation meters. And so think about how many people that could be, because when you think of a localized incident, with a CBRN incident, it can blow, it can spread, and you can have a lot more impacted people, but not necessarily people that need treatment or any sort of other assessment, but you're going to have to deal with them. Same with a chemical incident. Usually the footprint's a little bit smaller just because of the dispersion and things like that. Depends on the chemical. But even then, you're still going to have several, blocks, miles of areas where people potentially have had an exposure or are bringing around contamination. So screening decon centers, for each of these are going to require those specialized facilities. We're going to talk just a little bit about each of them here, and then we're going to dive into the radiological one. But if you are interested in talking about any of the specifics, we can definitely, as the radiation specialty team group, spin up one of our other specialty teams and, give a more in-depth discussion on any one of these at any time that you're interested. But for chemical, a lot of times, because of the nature of some of the chemicals, like if it's on the skin or it's inhaled or it has an immediate effect, it's doing, it needs to be neutralized to stop the effect from happening. So a lot of times these decon efforts are happening out in the field. They're at the actual scene through, the firefighters or hazmat teams are, deconning people before they're coming to a center. Sometimes not though, or maybe people are showing up, but they left the scene before they were able to be determined to need a decon. Biological has its own sort of considerations because the health effects may or may not be immediately recognized. And there's not usually a quick wand, as we learned through COVID. There's quick tests now, but when COVID was first happening, they had to send samples off for analysis, and it took several days to figure out whether or not somebody had COVID or not. So we won't be able to just easily, quickly screen who has it, who doesn't, and who needs what treatments. Radiological and nuclear, I'm going to lump those together. They are beneficial because we can use tools to screen and detect who needs additional treatment, who needs additional surveying or analysis or assessment. But the opposite of that is we do detect really, really small amounts, and those people may not need anything. The other piece is that when contamination for radiation is on someone, it's not an immediate, it's not burning their skin, it's not doing things in a chemical, like a chemical nature would. It is something that we can take a little bit of time to get off of their skin or out of their body. So we have time to do the assessment, and it's fairly easy to actually measure. And again, consider these specific kind of nuances. And as we move forward into the next phase that Frank's going to talk through, think about this, like why you might need to think about a different location or how you might need to reconfigure your existing plans to accommodate. So I'll go ahead and turn it over to Frank to go forward here about radiological incidents specifically.
Thanks, Angela. One thing that in a previous slide, Angela showed the number of individuals that could be impacted from a radiation incident, right? Well, let me tell you, there is, as she indicated, a big fear and misconception about radiation. We can't detect it with any of our senses. And so we're just innately in fear of those things. So when an incident happens, the CRCs are critically important because of two things. First of all, we don't want individuals who are not injured going to our medical facilities. So take a dirty bomb. The key word is bomb. You're probably going to have some serious injuries, and the existing medical facilities are going to be stressed just from that. The last thing we need to do is to have individuals come there that aren't injured, that may or may not be contaminated. Because at these CRCs, there are going to be a lot of people who are concerned, even if they were 10 miles upwind, that have I been exposed to radiation? These individuals we call the worried well, that are going to inundate our CRCs. And so we need this to really help our medical facilities. Next slide. So one good thing about COVID, I guess, if anything, is it kind of got us used to setting up pods and some contamination control. So the most important thing, like we said, in a CRC, Community Reception Center, which we're going to talk about ionizing radiation, is these individuals coming in, we're assuming potentially could be contaminated either internally, externally. So the difference is we're going to have essentially a contamination control zone or hot zone or whatever you want to call. We're assuming that there's contamination until we can prove otherwise. So other than that, there's a lot of the aspects of the pod are very similar to the CRC. You come in, you do kind of a triage or sorting, maybe some screening. The difference in with the CRC is if they are in the screening process contaminated, let's go ahead and try to decontaminate. And then once that's okay, they're in the clean zone. We're not worried about any radioactive contamination. We may need to do some radiation dose assessment, and then we discharge with some information. So we'll talk about the CRC a little bit further. So let's go to the next one. I did want to mention this. In any type of radiation event, whether it's radiological or nuclear, the early messaging always is get inside, and stay tuned. Hopefully, if people follow this, this will help us quite a bit. Public officials can then relay information that if you believe you're contaminated, this is what you need to do. You need to remove your clothing, you need to shower, and then stay tuned. If individuals will do that, that's going to really take a lot of stress off the community reception centers. And so then they can wait, because the community reception center is going to take at least hours, even if you've got agreements in place to go ahead and get things put together. Next one. So, you know, let's think, what are we doing at a CRC? We're doing contamination screening for radiation. We're going to decontaminate, you know, individuals or systems if need be. We're going to do some patient registration so we can kind of track what happened and track what happened to the people that have gone through. And then possible radiation dose assessment for those who have maybe received a higher radiation. So as I kind of indicated here before, you could have a lot of individuals. So the bigger, the better. Okay, so for here, like in Omaha, with our Douglas County Public Health, we've got some MOUs, you know, with like gyms, okay, schools where they have shower facilities. Obviously, we have one at our Baxter Arena, which is the University of Nebraska Omaha, which, you know, is a big sports facility, has a lot of locker rooms. So obviously, when we look at the considerations, these are pretty common sense: size, location. You know, what was the event? Maybe a place that you had, you know, targeted for your CRC, just because of destruction or problems of roads, you need to relocate. Obviously, the big thing is decontamination is simply using water with most of these contaminants. So restrooms, shower facilities, we have to, in any type of event like this, we have to accommodate people who have certain needs, functional disabilities. We have to accommodate for people with service animals. Since we're going to be doing a lot of monitoring and possibly showering, we need facilities that can, you know, handle, you know, are environmentally compatible. Adequate parking space, vehicle decontamination. And then we need even spaces for our responders and our staff. Next one. So here's kind of a better, I think I like this a little better in terms of the CRC. So you come in and you do a triage. And one of the things that we will probably do at our CRC is if a person comes in and if they're potentially contaminated, where are they going to be contaminated? A lot of times it's going to be on their hands and on their feet. And so one of the things we'll probably first do is we have like a ton of just like hospital booties, right? They use in OR and stuff. So just to try to minimize contamination. Contamination control is really big. As soon as they enter in, they're in essentially contamination control. We're not going to provide extensive first aid, but if it's a minor injury or burn or something like that, we'll take care. If it is something life-threatening, I think we all know that life-saving, limb-saving, takes precedence over contamination. So if they get through, we do a contamination screening with survey meters or portal monitors that can detect, small amounts of radiation readily. If they do set it off, what we do is send them to the wash station, which is just basically just washing them off, having them shower, removing their clothing. As you probably heard in like dirty bombs, 90% up to 90% of the contamination might be on their clothes. So get the clothes off and take a shower. Hopefully some of these individuals that come here have already done that through the early public messaging. Now, if they set it off again, you'll have them go through, and after they shower, if by chance they set it off again, then we would send them to a radiation dose assessment to try to pinpoint where is this radiation at in particular. Can we help? Is it external so we can help try to remove it? Or is it internal? And if it is internal, how are we going to ascertain what is the radiation dose? Typically, the way you do this is with a urine analysis or like a CBC, a blood count or something. Maybe at very specialized CRCs, you might be able to have the capabilities to do that. Other places, you might just end up having to refer them to a hospital to get that reading. Okay. Then after if they've gone through, they decontaminate or they didn't set off, they go to registration. That's going to take a lot of staff because we're going to ask a lot of questions. Demographics. Where were you? Where's your family? Is your family here with you? A whole bunch of different things like that. Where were you when the incident occurs? And we also might be even taking some medical information there. We had talked about exposure, which isn't contamination. So an individual could maybe receive a high radiation dose, decontaminate themselves, and maybe have received a high radiation dose, and possibly through the registration, we can determine if, from like some biological markers. I've been really sick, I vomited a few hours afterwards and this like that. Then we would send them to the radiation dose assessment. And then after they're registered, then, we'll have discharge them from the CRC, providing them with information and possibly, if we have the capability, there's maybe a lot of concerns. And we'll talk about this a little bit, as we kind of indicated, there might be some mental behaviors. Some people are scared, and maybe having mental counseling professionals there might be helpful. So like with any pod or CRC, the CRC, we want to keep the families together. We want to keep caretakers and service animals with the people they serve. And we need to be cognizant of those with access or functional needs. Okay, so let's move to the next one. As you would guess, a lot of contamination control. So we look in the upper left-hand corner, right? There's a portal monitor. They walk through. If they have small amounts of radiation, it readily will alarm. Geiger counters, the click, click, click instruments that you guys are probably familiar with, those are very sensitive and can really help pinpoint where the radiation is if necessary. If they are contaminated, we're going to need, supplies for them to take showers or to wash themselves. And if you don't even have, any water capabilities, if you can get moist towels or something to wipe it off. You're going to need a lot of bags for contaminated clothing if they need to remove it, and in ways to tag them. We talked about clinical samples. Possibly you can take them at the CRC if you're a specialized CRC. Maybe you'll have to send them to a medical facility. Then we have to be careful. We have to be cognizant of the staff themselves, right? And really, if probably from last year and all the radiation information you received, the radiation coming off any of these patients is minimal, but they may be contaminated externally. And so what we're doing is we're trying to do contamination control. And typically, standard precautions in a hospital are be good. So contamination control, and then providing badging to at least maybe one or several of the people. We don't expect very high radiation levels at all, or radiation dose to any of these individuals, but it's good to quantify it. And then you're going to generate a lot of waste. So there is kind of a more complete resource list in the CRC toolkit template. Next one. And not everyone needs to be fully, geared up. If you are in the clean zone, these people there's no indication of contamination. So you don't need to wear any of this PPE for radiation purposes. I mean, if you want, maybe you need to wear gloves or a mask for other reasons, health issues, but not for radiation in a clean area. And then for the initial screening, okay, like where you're doing the triage or something like that, you just need some basic contamination PPE, booties so you're not tracking around, gloves and a lab coat. If you are helping individuals for decontamination or directly, working with the patient, then you need something more like a Tyvek suit or something that's that can, that's is flash proof or something like that from liquids. And then when you're dealing obviously with splash potential, you may want to wear goggles or face shield and certainly head covering. Next. The registration, I only just put a little excerpt. They're going to be asking a lot of questions. Okay, who are you? Have you had any of these symptoms and stuff? Where were you when it happened? Things like that. And those aren't typically involved in other reception centers, but we want to do this to go ahead and track these individuals to determine, possibly is there a need that we need to contact them later or see what happens with them. Next. And one of the things we talked about is because of the fear and misconception about radiation, there is oftentimes a lot of say psychological health needs associated not only with those individuals who are affected that were involved, but possibly with your staff as well and those first responders. So it's good to get information out there. Having, if you possibly can, possibly at the discharge or maybe even up at early on as they're waiting at the triage to answer questions. At the discharge, having some basic information about radiation risk to put things into perspective. And if all possible, if you can provide mental health professionals for concerned individuals, and hopefully the staff can also maybe recognize individuals that are potentially experiencing a mental health emergency as well. Next. In terms of staffing considerations and job functions, the toolkit does provide a little bit about the job actions for the various CRC staff positions. And you may need a lot of people to monitor. I put here for 350 people. Look, you're going to need quite a few people to do 350 individuals per hour. Now, in an event, 350 sounds pretty good. That's almost like what, 1 every 10 seconds. But in a big event, you could certainly have thousands, or to be quite honest, tens of thousands of individuals wanting to know, did I get exposed? And as you can see, the registration staff takes quite a bit. Next one. To help you kind of estimate the number of workers, there's a CRC simpler tool program. And what you can do is just enter in some basics about how many people you think are going to come, how are you going to set up your CRC station, and kind of put in, well, I think we'll have 2 people at the triage and we'll have maybe 7 at registration. And then when you go ahead and put in your inputs, you go ahead and next page. You can see this is what the throughput is, average time spent, and it can be a good tool to kind of indicate where are your bottlenecks. Where do you need additional people at, or how you should, divvy it up. Okay. You want to take this or?
Yeah, I think we'll turn back over. So thanks so much, Frank, for digging through some of those big sections of what we need to consider for radiological response. One of the big questions, though, is who has responsibility for the planning, the activation, and the various operations of the CRC? So as you heard from Frank, there's a lot of different considerations for, specialized bioassay or other kind of specialized resources that need to provide either care or support or information. And there's a lot of logistics. There's, the supplies that he talked about. Those are the additional specific supplies, not to include the stanchions for forming lines and, different tables for people to set up for registration and chairs for people to sit in while they're waiting and all of those kinds of things. So one of the key things, and the template that we're going to share with you for the region will have, contact information for some of the specialized resources for radiological support, particularly our webpage also has those. But when you're looking at your plan for a radiological incident and the community reception center, it's going to have to be an important collaboration between many entities within both the state and local support agencies, which includes emergency management, public health, the radiation control program, which every state has one of those, and then has various assets available at the local level. Some go directly to the state for those assets. And then healthcare facilities and providers are, a big component of that for that medical first aid or other types of integration with either providing people at the CRC to take those urine and blood samples or receiving people from the CRC to do that next stage of internal dosimetry assessment. So one of the big important things here that just resounds all the way through, whether we're talking about a radiological incident or any of the other types of reception centers that would be needed for natural disasters, chemical, biological, the importance of facilitating a coordinated and consistent incident response across the healthcare and community is vital. Cross-boundary coordination is super important. We saw some good and some bad for that with COVID on how we were able to collaborate in various ways. But, we heard everyone talking about where they could get vaccine, where could they get testing. People were, crossing boundaries to look for assets. And so knowing that there might be people far outside the incident, especially for a CBRN who are concerned or want information, they may be traveling to you to get that resource, or maybe want your community that, is far from the impacted area to spin something up to address their concerns or their needs. The movement of public and patients, load balancing. So, if a community reception center is set up somewhere and that's where most of the impacted area is, they could be overwhelmed and have enormous wait lines. And maybe another CRC really close by could be established. And so working together to say, hey, I have one that could be set up nearby you if for some reason it's in your area, and vice versa, having those kinds of cross-boundary agreements. Consistent assessment and triage guidance at all facilities is really important too. So that's where the plans are really key in determining who's making those kinds of recommendations on what is considered radiological contamination that needs follow-up versus just normal contamination that can go home. They can go home and be, washed in a shower normally. So, if one center is handling things one way and another one's handling another way, quickly people will figure out that there's two different ways, and they're going to become very distrustful of what's happening because they're getting mixed messages and hearing different things. So a big coordinated community together is very important. And tracking and managing records are going to be very important. As you heard from Frank, the registration form for a community reception center for a radiological incident is going to include a lot of additional assessments, questions, things that will probably be looked at later by dose assessment teams, radiation specialist teams, who will treat that a lot like contract tracing, right? So it's going to be, okay, well, we looked through, your paperwork, and it looks like you were in this area for this period of time, and we've determined that you should have some additional follow-up because you may have received a radiation exposure, even if when they arrived at the community reception center, they had no contamination on them. So there's some assessment that's going to happen over time. And that tracking and that individual information that gets gathered at the CRC is where that all starts. That is the place. And you do that a lot with biological contract tracing. And we did that a lot with COVID, but there might be other people that need to be involved from a radiological aspect. And, but from an epidemiological perspective, all of those epidemiology groups know how to do contact tracing. And so leveraging how they know how to manage all of that tracking, paired with the people that know what kind of information they need to know, doing that ahead of time, making sure asking the right questions when you have the person in your community reception center will really help to make sure, you have less of that outreach out to the community that's necessary later. And keep in mind, as Frank mentioned earlier, it's very likely it's going to be several hours before a community reception center is set up and ready to go. However, if you do planning ahead of time, where you have a pre-established facility location or multiple possible locations, you have staged equipment in various places that is ready to deploy and ready to go, especially those specialized assets that might not be readily orderable or available. And just-in-time training and job aids ready to go, so that when somebody comes in, whether they're a volunteer or an emergency responder or a healthcare professional, they've likely never served in a radiological incident before, or really know what this role entails that they're being tasked with at the CRC. And so if you can get them up to speed more quickly, you can open those doors for the public more quickly. And the more quickly you have the community reception center set up, the more quickly you can ease concerns in the public and keep the pressure off of the healthcare facilities, which is where people will go for those answers, especially if they're concerned about their health. So we've just given you a lot of information about you're going to need all these technical assets. So who can help you? Who can help with this population monitoring? Now, these assets are going to be able to help you with a lot of other parts of the radiological response. So it's important to know what their roles already are. So that if they're already tasked in your plan to do something else, that you need to look for another team. But particularly, you're going to be able to look at your health department, epidemiologists, toxicologists, others who are used to doing assessments of chemical, biological, radiological, nuclear exposures. State radiation control program staff are also good at assessing and connecting with all of those assets that can do that work. But more locally, your hazmat teams, they are there to, they know how to do that field decon, and they understand the screening piece and the assessment piece of radiation. And so integrating at least some aspect, they're probably going to be busy if you ever have like an actual radiological incident, but maybe there's an aspect of that team that can be there to be a support. Civil support teams are also a very important resource, and I do see a note in the Q&A for the 7th CST Medical Operations out of Missouri. So I encourage you all to reach out if you're in the Missouri area to your CST. They have a lot of assets and practice that they do on patient movement, and they understand also the CBRN realm, so they can be a plug-in for various aspects of the CRC. Hospital radiation staff, medical specialty teams, the poison control centers, and the radiological operations support specialist are all important assets that can bring the technical component, particularly for the radiological piece. But as you saw earlier, we have a chemical specialty team that can also, if you find yourself in a chemical incident, those individuals can help plug you into poison control centers, and others who can help put the actual risk and need for treatment in context. So just a bit more about the radiation specialty teams, just as a reminder, this is what I talked about earlier. These teams, are comprised of a couple of people who are the team leads, but their goal is really to be compiling and sharing and coordinating assets across our region, 7 states. And as we showed before, there are many of these response systems across the nation, and they're all doing the same thing. So the more we can share resources and share assets and plug these resources and assets into our plan, again, the better off that we'll be. And then just, again, the radiological operations support specialists, for those of you that haven't heard of that before. It's a program out of the FEMA office, and it's a multi-agency collaboration between Department of Energy, DHS, FEMA, and the Conference of Radiation Control Program Directors. And the goal is to take individuals who work in radiation every day, whether it's in a hospital, a laboratory, at the state, at the federal level, or academia, anywhere. and train them into how to respond in an emergency and how to support the various aspects of radiological emergency response. It's a volunteer role. It's treated a lot like the Medical Reserve Corps or the Volunteer Reserve Corps that, support in other ways. So this is something that various states are spinning up. If you have questions about that, feel free to reach out to Frank and I, and we can plug you in with the ROS that are available around the region. And you can reach out to them to help you with your planning, to support various portions of your plan, especially in the community reception center. And I just, as we wrap up here, want to point out some community reception center planning resources. As we mentioned a few times throughout, we are going to have a Region 7 specific CRC regional planning template. It's going to be based off of a lot of other planning templates, and there are national level templates and toolkits available, as you can see here on the screen, particularly from the CDC. And CDC isn't the only place you can get them, but these are some key ones that are a good place to start if you're just starting to look at it. But we're hoping that the Region 7 planning template can give you some specifics about the regional contacts and the regional considerations we might need to make. But for the most part, they're very, very similar. The population monitoring website is great as well, because it'll take you to, you can take a course. There's some tools that you can use. There's a board game that you can play about how a CRC operates to get people to understand what, the various aspects of radiological response are. And then it links you out to other resources pages as well. Our Region 7 Radiation Specialty Team website will also have links to this, as well as many others. And it's under construction at the moment, but I encourage you to go to that website over the next few months to see where you can find more resources when you're ready to move forward in these planning efforts. So I'm just going to end with a little bit of a video here. The CDC reaches out and coordinates with a lot of communities to help them with their community reception center planning. And there are some success stories that they put out on their website. And one of them kind of resonated with me from the Texas group. And so I'm just going to play a bit of it. We'll stop at about halfway. It's just a couple of minutes long. But I just want you to hear about some of the considerations that they made throughout their planning a few years ago.
After completing a population monitoring exercise, our partners were shocked at the amount of planning and resources it required. It helped them to see why having a coordinated plan for radiation emergencies was so important. Hello, my name is Chris Moore. Together with my colleague Ray Walker, we bring over 50 years of radiation emergency experience to the Texas Department of State Health Services. 10 years ago, when emergency responders thought about a radiological event, we all assumed the response would be handled by the fire department and hazmat teams at the scene. That changed after the Centers for Disease Control and Prevention, the CDC, held a meeting about public health's role in setting up community reception centers after a radiation emergency. I saw that we would be responsible for population monitoring and radiation effects tracking for the public and the environment. The magnitude of that task made us realize we had a gap in our preparedness plans. To bridge that gap, we began to expand our radiation response program and make our colleagues aware of their role in a radiation emergency.
Since then, we've educated city, county, and state response leaders about the importance of radiation emergency preparedness. We helped them think through the training, equipment, and volunteers their communities would need to complete response activities. In Texas, our first step was to hold tabletop exercises in cities across the state, in some cases bringing over 200 people together. By simulating the logistical and communication challenges of a population monitoring scenario, we demonstrated to our local partners that radiation emergency planning is critical. That fueled demand for additional preparedness actions in their own communities. We then assisted Harris County, El Paso, and Waco in hosting community reception center exercises. That helped bring together local and regional response partners and gave them an example of how they could manage a radiation emergency.
One of our constant challenges is the size of Texas. Coordinating resources across such a large state is complicated, especially because our public health system is split up into a number of regions. In terms of radiation preparedness, our goal is to help each region identify their capabilities, both for themselves and for the regions surrounding them. It's important that they know what they have, what they need, and what they can supply to others in an emergency. Knowing that allows us to work together to plan how resources and volunteers can be tracked and shared to support radiation emergency response across the state.
Currently, we're making sure all regions and major cities in Texas have a chance to develop and exercise their radiation emergency plans. Response activities depend heavily on having the right people in the right places. One way we hope to build that capacity is by improving how we train and identify Medical Reserve Corps volunteers. Because we have MRCs with radiation volunteers, one goal is to make sure they receive the training and guidance needed. And CDC material has helped tremendously with that. In addition to our State Radiation Incident Annex, we want to publish more radiation plans and procedures for our State Medical Operations Center and Regional Medical Operations Centers, similar to what we've already developed for floods, fires, and hurricanes. Having those plans.
So we'll go ahead and stop the video there, but hopefully you can see, Texas is a great example of, a huge state with a lot of regions, which could feel, except for the jurisdictional differences, a lot like our Region 7, right? So if we can come together in Region 7 and work together across our healthcare coalitions and our health systems and our response agencies and public health agencies, radiation control agencies, and other response entities together to figure out how we all fit, I think that this, really seemingly large task of screening large numbers of people, providing them the care and community support they need throughout the incident, and tracking them ongoing can really feel a little bit more manageable. So hopefully over the next couple of years, we'll be able to work through this as a region. And Frank and I are very excited to work on that with all of you as you want to tackle this in your community. And I think that's what we've got, and we'll kind of go over to questions. Thomas, if you are ready for that.
Perfect. Yep. We have a number of questions that have come in, actually. I'm just going to go in order here. First off, wanting to know, what about exposure or cancer registry after the incident? Should you collect or start that at the CRC? And if so, who is responsible for that? And kind of a follow-up on that, asking if contact tracing would be a good example of how the results of monitoring would trigger that data collection and follow-up.
Yeah, that's a great question. And hopefully we addressed a little bit of that going through this, but it's going to be different on each jurisdiction on who's actually responsible for that longer term tracking. But it's likely going to fall into public health or the radiation control program's responsibility. Now, the larger cancer screening could get set up by a university or some other longer term tracking, tracing. I know many of you may know of like mesothelioma tracking registries. There's also some, back in the past, cancer registries from exposures during maybe the Cold War era and the atomic energy work that was done. Those things will take a lot longer to set up, but it all starts at the community reception center and in those communications that start early in the event. We need to know who was there, and their memories are going to be the best right then about how long they were there, what kind of exposure they might have gotten. So the more we can capture, the better, but also keeping in mind we need to facilitate that through. And yeah, I do think that contact tracing and using that model and how that's tracked and organized and followed up on is essential. It just needs the tweak of the radiation specific information. So.
Okay. Next one's asking, how do you manage the potentially contaminated water runoff with a radiation decon at something like this kind of a center?
Sure. So the early in the response, the radiation contamination in the water and runoff from decon activities is not as critical. Like, we need to be taking care of the people, getting the scene under control. As time goes on a little bit longer, we're going to pay a little bit more attention. If there is a way to collect the wastewater, that's great. I know some hospitals and facilities have, special tanks that can divert raw water into, another tank. But if we have a lot of people and a lot of water, we're going to run out of that pretty quickly. So long term, we will eventually figure that out. But as Frank said earlier, the amount of contamination on most of the people coming through the community reception center is low. And so as that's being rinsed off or wiped off, especially if you're using baby wipes or something, those are gonna, not be a water source. They'll go into a bag, that will be tracked. We will have the environmental groups come in and figure out the best way to collect water. But in the meantime, we're not gonna wait to set up and start deconning people, for a whole, water collection storage system to be set up. But it is something to be prepared to address as the incident goes on.
Right.
further.
After an event like this, you'll get FERMAC, a lot of agencies. There's going to be, when a plume is released, there is going to be a lot of monitoring and sampling of water, surface water, drinking water, of crops, of milk products and things like that. So, and like Angela indicated, really the individuals, even if we have thousands, the amount of radioactivity that's going to be removed, while if possible to control it, the most important thing is just get the contamination off the individuals. It's going to be small fraction of the larger contamination issue.
So your next question asks that a radiation CRC requires a lot of specialized equipment, and how does a community find funding for this kind of specialized equipment, or just what are some of the other options that may be out there? MOUs, federal assets, working with private industry, any number of things. I guess just general question of how to help fund something like this.
So I think it takes a team. I know that some of the radiation funding from last year was used by some of the jurisdictions, the healthcare coalitions, to purchase some equipment for their jurisdictional area. And so, sharing those resources, not everyone needs 10 Friskers, but if you know where those 10 are across your jurisdiction and you can leverage those for the community reception center, then, I think that's where that coordination and community together in their planning efforts can really kind of leverage the use of these specialized assets. And I think you can tap in then to other resources. And I'll turn over to Frank a little bit, because I know you guys have some portal monitors and things that are kind of ready to deploy as well, but that you keep at UNMC.
Right. What we did last year in our state was identify at all the medical facilities what their capabilities, monitoring capabilities, just so we would have it on hand. And so also so the medical facilities themselves would have an idea of what they had on hand and what they need if something came up. We've set up some MOUs, for example, with our 2 nuclear power plants, where we can use their portal monitors. Obviously, they have to have some, for some of their decon centers and things like that. I'm not so fluent on the grants out there. I know they're out there for getting them. I keep thinking that, especially here at Nebraska Medicine, where we've been pretty involved with this disaster health, response ecosystem, we have individuals, and maybe we can check into it, what's available, to kind of get back on that. But we have universities, especially medical centers, have typically a lot of expertise, or individuals that even work in labs that know how to use a meter, which is going to be very helpful.
Okay. This one, I think you kind of already touched on it a little bit, Angela, talking about the Missouri CST and doing all that. Really, it's just kind of the general question of educating hospitals. How do we educate hospitals about capabilities and assets from the different CSTs, which every state has one. So that's something to keep in mind, even for our folks who are not necessarily in Missouri or in Nebraska. I mean, Iowa has one too, and Kansas is going to have one. They're all going to have one. So, but thoughts on better education there, I guess.
Yeah, I think, I'm very glad that you were on this call and put that comment in. I think that this, Region 7 Regional Health Response ecosystem, that's exactly what its point is for, is to bring together all of these various groups. And, you know, the healthcare focus is one of the primary responsibilities of this group. And so I think that we can really help to make some connections. You know, we'll take that back on our radiation specialty team website and maybe have a little, we do list all of the resources, and CSTs are some of those resources listed for assets for radiation, but we'll make sure that they're out, you know, in the front page. And also maybe if you have any links that you'd like us to link to, or fact sheets that you want us to put forward, you know, we can make a little link and have that on our website, and, you know, remind all of our healthcare partners and hospitals to, you know, visit that if they're interested in resources, not even just from the rad or chemical specialty, but from patient transport and other types of support.
Perfect. This one's asking, they found that many radiation physicists have varying opinions as to what is quote unquote safe exposure level for specific isotopes, and I'm guessing just different isotopes, of course, are going to have those varying levels. But they're looking for, are there national standards or recommendations being used as a starting point for discussions and justifications? I guess they're looking for a resource to kind of bring to the table to folks and say, this is where we start.
Absolutely. So that is a great question. And unfortunately, that is true. No one wants to use the word safe. And we need to learn how to use the word safe, because we say safe for chlorine exposure and other types of things, right? We'll say it's okay to clean your bathroom with chlorine, but it's not okay at this level, right? And we don't discern the levels there. So we really do need to figure out how to communicate more clearly where we have real concern, where we have a little bit of concern, and where we really shouldn't need to spend resources on a concern. So, however, that is not necessarily where the community is, but there are a lot of resources that can point to places to start. The National Council on Radiation Protection and Measurements, so the NCRP, has reports and commentaries that can provide a lot of the bases and justification for various levels that are used. And those are usually the reference that are used in federal guidance documents. And so that means our federal guidance documents, such as the FEMA planning tools for either nuclear detonation or radiological dispersal devices, or even chemical incidents, they're all going to be pointing back to those resources. So for radiological, we've got, you know, the NCRPs. We also have a lot of other reference documents. And so for those of you familiar with the nuclear power plant world, there's a FEMA Rep 21 and 22 that kind of points to particularly the contamination threshold numbers, and it provides a lot of the basis of why certain numbers were picked based off of cancer potential. And so, you know, looking at those documents and using those, not necessarily as just like factual, this number is the only number, but the basis that's within a lot of those documents can be used to help generate and justify additional numbers and additional thresholds. One also place that I would recommend that you go, it's called radresponder.net. And I don't know if we can type that in somewhere, Thomas, but it's RAD responder.net. If you go there, you have to have an account to log in, but once you're logged in, there's a resources page, and there's a tool, it's called a ROS toolkit, and it's really meant for the ROS, but it's available for everyone. And inside there are tables and quick reference guides and links to the various resources that point to those. And it gives you pros and cons of using different things. So for example, if you're going to set up a hot zone, it'll say the pro and con of using the ERG's terminology versus maybe the RDD guidance documents terminology. Because both are very reasonable, but one could be better in one situation than another. And so that really breaks it down into table breakdowns that are easy to kind of digest when you're looking at the numbers and why one might be good in one situation and not another. I don't know if you have anything you want to add there, Frank. So,
well, I'm a radiation physicist, so I'm not sure if I should respond. But anyway, that is so tough. You know, how do you define safe? And that's where, you know, when these people are leaving this discharge, you know, of the CRC, to me, we always assume there's some risk. Like even if you walked into a room and someone had been smoking, there's some risk of that smoke, right? So we assume for conservative state that any amount of radiation is, hypothetically, no matter how minuscule, could potentially, be detrimental, even though it's incredibly low. So what we try to do probably is try to put things into perspective of, normal radiation events that we receive, how much radiation we get from natural background radiation every day, things like that. And by using those kind of documents that Angela said, you can maybe have them put it in perspective, like, okay, this isn't maybe that big a thing at all, or at least put it in perspective when it should be concerned and not.
I think taking from the chem world and the environmental health, public health person in me, it's that the dose makes the poison. I mean, you're going to run into that with anything. I don't think this is any different. So, let's see here. I do want to point out there's a couple. These are comments rather than questions and everything. Where Angela and Frank, you guys have talked about taking a community and everything. It points out that CERT teams as well as MRCs, Medical Reserve Corps teams, they can also be very helpful with some of this stuff. Some of them even having specialized radiological teams themselves. We have a comment in here talking about Homeland Security grants, MRC funding, and other sources can be acquired based upon your funding applications for helping to fund some of the stuff that you have going on. Of course, always for any kind of an event like this, make sure you are going through emergency management to access things like the CSTs, unless you want to foot the bill yourself. So making sure to use proper channels, not just for funding perspective, but also just for situational awareness, resource tracking, all of those. There's different reasons for why you want to make sure to go through the proper channels there. This last question that I have on here is talking about for biological incidents, the CDC has a little tabletop board game thing that they've made called This Is a Test. For radiological incidents and everything. And the question is wondering if you know if there's any kind of similar games like that or anything for the rest of the CBRNE letters for our chemical and biological and all of that kind of stuff.
Yeah, I'm not aware of any for the other CBRN letters. I do believe there might be one for a pod. There might be a pod test game as well, but I'll have to go look for sure. But yeah, definitely it was piloted for Radiological Community Reception Center. It's actually a pretty fun game. And it really does help you figure out where all the different stations are, what the various impacts could be. And so I would recommend that as kind of an activity to do with all your players. Oh, and thank you, Arnold. There is definitely a version for pods. Thank you.
I'd say there's the games are often the ones that are forgotten in that whole exercise. What I can't even remember, gamut, if you want to think. I mean, going from full scale to discussion and everything. So that's all the questions that we have coming in there and anything. I'd like to thank everybody for joining us today. I put a couple of things in the chat there about how the webinar will get posted to our different channels in the next couple of days. Make sure you're checking back in on any kind of events that we have coming up, as well as how to get your CEs, your continuing education credits there. We'll make sure to get that stuff sent out to everyone. I want to thank Angela and Frank for coming on and talking about this topic with us, and thank you all for joining us today.